everyone. My name is Halima Siddiqui, and I'm the project coordinator at Health Nexus. So, Health Nexus oversees several provincial initiatives related to FASD. The FASD provincial website, where you can find recent and up-to-date information about what's happening, learn more about resources and tools, and find out services available in your local community. We also allocate subsidies every year to 40+ support groups for individuals with FASD and their families. And we designed an online training for service providers from various sectors, including healthcare and nursing, education, mental health and addictions, justice and corrections, and community and social work. During the presentation, you may be tempted to ask questions at the end about yourself or loved ones with FASD. Please do not use any identifying information to protect people's privacy. By law, we have a duty to report to Children Aid Society or the police any threat to a child or direct attempt to harm yourself or someone else. Presenters cannot provide clinical advice, as this would require professional counseling and more in-depth knowledge of the situation and behaviors at stake. Today's discussion provides information about latest research, evidence-based practice, or general education tips and advice. If you need ongoing support, please consider connecting with your local FASD worker for supports, or join one of our Health Nexus support groups for individuals with FASD and their families. You can find this information on our website, fasdinfo.tsaf.ca. Also, please ask your questions in the Q&A section that should be at the bottom of your Zoom panel, and then we'll answer them towards the end of the presentation. Before we start the presentation, we would like to begin by acknowledging the Indigenous people of all the lands that we are on today. While we meet today on a virtual platform, let's take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous people and their culture. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past, and to consider how we can each, in our own way, try to move forward in a spirit of reconciliation and collaboration. Today, we are welcoming Dr. Keith De Silva, who is the Chair, Division of Pediatric Dentistry and Assistant Professor at the Schulich School of Medicine and Dentistry at Western University. He is a dual fellow of the Royal College of Dentists of Canada in both pediatric dentistry and dental public health. He started his career in clinical practice, having owned 2 busy pediatric dental practices in the Greater Toronto area. After spending 8 years in private practice, Dr. De Silva shifted focus and is now primarily involved in clinical teaching and research. His research program works towards improving access to services and quality of life through community-based solutions and policy change. This involves an evaluation of government policy and programs, barriers to service, and decision-making. Dr. De Silva has been an active member in the dental profession, having volunteered for several different associations. This includes currently serving as the RCDC Director for Dental Public Health and a board member with the Canadian Dental Specialties Association. He is the immediate past president of the Canadian Association of Public Health Dentistry and a past president of the Halton Peel Dental Association. He also sits on several committees with the Canadian Dental Association, the Royal College of Dental Surgeons of Ontario, and Health Canada. We're thrilled to listen to the presentation. Once again, please ask your questions in the Q&A, and I'll provide more information and links in the chat if need be.
All right, see the right screen? Perfect. So welcome everyone, and thanks for having me here today. Obviously I'm a dentist, and thank you for the introduction. So this is an area that's passionate to me. Let's get the slide here. So I'm calling, zooming in from London, Ontario. So just wanted to acknowledge as well that, the campus here at Western University is located on the traditional territories of the Anishinaabeg, Haudenosaunee, Lenape-Wack, and Chinantun nations on lands connected with the London Township and Sombra Treaties of 1796 and the Dish with One Spoon Covenant Wampum. This land continues to be a home to diverse Indigenous peoples, whom we recognize as contemporary stewards of the land and vital contributors to our society. So I was born and raised in Ontario and spent most of my professional career here. I did take a slight detour. So I was living in Saskatchewan for the last 7 years or so. And a lot of that, relationships and understanding that I built while living kind of in a different part of Canada has increased my appreciation of being a settler in a land and reconnecting with communities throughout Canada, and just the subtle differences we have from province to province, and depending on how far from the border you might be living. And so, it opened up my eyes a lot to different ways of living, and a lot of that comes out in how I perceive healthcare nowadays. Part of my time in Saskatchewan as well, really got me connected more with the FASD community. So, um, when I first arrived in Saskatchewan, it was more in a clinical practice based, and I was very quickly connected to the good folks at the Saskatchewan FASD network. They're very convincing people. So after doing some sessions with them, I ended up on their board for 6 years, and that's really helped inform not just my clinical care, but a lot of the research that I might present later on in this presentation. So that's a little bit about me. I have no financial conflicts of interest to disclose at this time here. But my first kind of um, foray into dentistry is as a pediatric dentist. So within pediatric dentistry, we obviously treat young children, particularly those who can't normally sit in a dental chair for routine care. So whether that's due to their age, to their behavior, or the majority of my practice, which were kids with chronic medical issues, or various uh, conditions that might preclude them from receiving traditional care in the chair. And part of understanding the barriers that they were facing beyond just individual level really got me into dental public health as well, which we really look at policy and programs. So what are the gaps that are preventing patients from getting into receiving health care, or in my case, dental care? So it's kind of became an evolution of the way I think and how I practice, and that I spend part of my time treating individuals, trying to improve their oral health, but really trying to work on improving policy, and whether that's through research, through teaching, or through advocacy, on trying to make sure that every Canadian has the access to care that they deserved. And a lot of those themes are going to come out throughout this presentation. So again, my main research focus here at Western is beyond just healthcare, so improving access to services and quality of life. And sometimes that involves facilitating navigating the healthcare system, sometimes facilitating support services, whether that's through housing, income security. But a lot of the similarities we found in individuals not being able to access dental care or get into a dental office, we found a lot of parallels to just navigating government systems in general. So we'll talk a little bit about that today as well. So I wanted to start off, as a good public health person, just with a little bit of data. So we'll talk a little bit about the state of oral health in Canada, look at some of the conditions that worry us a little bit more and who they affect disproportionately. We'll then review, more specific to care when it comes to FASD and some of the subtleties that we've observed when it comes to their oral health. And then lastly, we'll look at some of the barriers and hopefully solutions on ways we can improve that access to care. So, good data comes from a good screening surveillance program. In Canada, we have almost annual reviews through Statistics Canada on healthcare measures, but we're very lacking when it comes to oral health data. So the data here from the last oral health version of the Canadian Health Measures Survey was from 2010, so it's a little dated at this point. We unfortunately don't have an annual screening of the Canadian population, but it's still better than nothing. The most recent version will be released next year, so that's 15 years after this 2010 cohort went through. But for reference, before 2010, the last national survey in Canada was, I think, 1972. So it was almost 30 years of oral health decision making, we'll say, without good data. So that explains a lot of the barriers that we've historically seen. So at least in 2010, when this national survey came out, 85% of Canadians reported that they had good health. Where 75%, almost three-quarters of Canadians were able to visit a dentist. And this was generally seen as positive. If you get an A on a test, so 85%, you're pretty happy with yourself. And both the dental profession, the public, and for the most part, the government, they looked at this as a sign that the system was working. If you really dig deeper into the data, you can see, very quickly some of the disparities that exist. So while 85% of Canadians reported good to excellent oral health, you have that 10 to 15%, so 12% of Canadians who, avoid food due to problems. So that's, something that's we need to sustain ourselves. 12% of Canadians have ongoing oral pain. So that's really pain within the last 12 hours on a consistent basis. And, clear disparity when it comes to income, um, depending on your income level in terms of reporting pain. So really, while 85% of Canadians said they have or report that they have good oral health, we're really more worried about that 15% who reported poor or average oral health. And there were clear signs and signals in terms of specific populations that were overrepresented in this group. So this includes seniors, low-income adults, specific Indigenous populations, particularly the further north you go, and then the focus of some of my work are individuals with special needs. So, I first want to talk about, one of the main oral health conditions that we always worried about, and that's either tooth decay, dental caries, or cavities, as they're commonly known. So, in this picture here, we have a very young child, so maybe 2 years old. And these kind of white spots that you're seeing are really the first signs of tooth decay forming. You can see a tiny little hole starting to develop here. And while it's always sad to see, someone this young, 1.5, 2 years old, developing these signs, there is a light at the end of the tunnel, and that, someone's actually looking in this kid's mouth at this stage. So there's still a lot of prevention that we can do to prevent this from getting worse. So whether it's applying some medications or some less invasive techniques to really arrest the disease from progressing to more detrimental conditions. So, we fast forward to a 3-year-old who again didn't have the opportunity to be seen for whatever reason, and we'll kind of go through some of those specific barriers. But you can see that this is a progressive disease, and so what you're seeing here is just larger holes forming, some staining or discoloration of the tooth. This can now potentially affect the self-esteem of the child with all these spots on their teeth. And then, some of the more extreme cases that we've seen, 4 and 5-year-olds who, for whatever reason, just can't get into an oral health care provider. And then it's just almost complete breakdown of their teeth. So again, you're dealing with infection, with pain, difficulties eating, and it affects their overall quality of life. So, in terms of understanding, at least at a very basic level, some of the root causes of dental caries. So, very commonly we kind of understand that, in order to have tooth decay, first you need a tooth present in the mouth. But there are very specific considerations that might make your tooth, be at a higher risk. So, whether that's how deep some of the grooves, are in your tooth, the quality of the outer surface of the tooth or the enamel, all of these things can affect how bacteria, get involved and where they situate in your mouth. We all have bacteria in our mouth. Some are better for us than others. And so really it's a balance between cavity forming bacteria and some of the more healthier ones that are there. We're specifically worried about bacteria that produces acid. So, some bacteria will digest carbohydrates to produce an acidic environment in the mouth, and that's really what causes tooth decay or the breakdown of teeth. And lastly, there are dietary factors. So, we typically think of sweets, but really it's any type of carbohydrate or sugar that this bacteria is going to break down and change the pH in our mouth. Surrounding all of this is, of course, our saliva or spit, which can, effectively buffer some of that acid to a point. But there are, various medical issues or medications that we take that can alter the composition of our saliva that puts us at a higher risk. So very commonly, we know that sugars and sweets tend to be the enemy of teeth. But I just want to reiterate that, one of the messages we're trying to get out there is that really any carbohydrate can be broken down. However, these are all healthy foods that you're seeing on the picture. So, it's more about modifying how we eat certain foods as opposed to avoiding foods. And I usually follow this up with this slide here. So, this was an actual health promotion campaign. So I borrowed this poster from the wall, and really instantly you can see some problems with the messaging here. So I think most can appreciate that sugary sweets, sodas, could be bad for our teeth. But if you look on the other side, we have refined carbs such as chips, crackers, bread, pasta. Crackers, bread, and pasta is pretty much the staple diet of any 3-year-old or kindergarten child. So, we can't really associate that with foods you need to cut out. If you're from an Italian family, seeing pasta on, something that's a public enemy for your teeth, that's not really sensitive to, a traditional diet, let alone something like fruit. To see fruit with, a skull and crossbones kind of beside it again is the wrong messaging that we've been traditionally portraying in the oral health world. And so I think we've done a little better work in terms of modifying how the frequency of certain foods is more important than what you're actually eating. So I usually like to think of how dental caries forms in as simplest of terms. So cavities are formed when there's a breakdown of the outer surface or the enamel, and this is caused by an acidic environment. And really, it's the bacteria in our mouth that are producing that. So when bacteria will digest or eat sugar, they'll produce this acid. That will form the cavity. And so, we do have lots of different options in this chain on how to prevent or improve these outcomes, whether it's modifying the diet. So again, just trying not to overload on carbohydrates at specific times during the day, or leaving sweeter foods to big meals times when you're producing more saliva to buffer it. We can control the bacteria, whether that's through guided oral hygiene, or in some cases there are various rinses that can help reduce bacteria counts. And then, if it's a saliva-related issue, certain medications to promote a better buffering capacity as needed. So one, it's understanding what the risks are and how best to prevent for each individual. So, beyond just the tooth, the diet, and bacteria, there are other known risk factors that tend to lead to a progression of dental caries. So whether that's adequate exposure to fluoride, and fluoride can come from the water sources depending on where you live, or from topical things like toothpaste or mouth rinses, but just making sure that there's enough fluoride available at times. Diet, sleep time routine is very important. When we fall asleep, we're not producing as much saliva or buffering. And so, being able to make sure that there's no food for the bacteria to feed on overnight, particularly in younger kids, is something that needs to be monitored. Basic oral hygiene. Some habits, can affect the progression of caries, whether it's digit sucking or, in some areas, dipping a pacifier in a sweetened substance to help soothe the child, is often seen. We'll talk about some of the special health needs in a few slides that have some specific indications for heightening risk. And then there are familial factors such as, families or children who've had a lot of cavities. It tends to be passed on because the bacteria is transmissible. And then, most of those are individual factors, so things affecting, one patient. But we also have learned a lot more about some of the, the more social determinants, we'll say, in terms of socioeconomic status and family status that can affect an individual's oral health. So, I've always liked this. It's kind of a a large diagram, but it really puts things in perspectives for me. So this was done by a pediatrician, maybe a little over 10 years ago now. So, it's recognizing the importance of some of these individual factors for oral health, such as diet, bacteria counts, and the tooth itself, but realizing that our health is influenced by more external factors beyond an individual's control. So whether this is being able to access the healthcare system, social supports, physical safety, different cultures, different diets, yeah, and realizing and recognizing that as healthcare providers, we probably haven't done well enough to incorporate these into our individual patient care. So it's putting it into perspective that there are lots of other challenges faced by different individuals when it comes to being able to have optimal healthcare outcomes. So again, looking at pediatric populations, at least for the start. So in Canada, we know that tooth decay, is actually the most common chronic disease in childhood. So we often don't think of it as a disease process, but that's exactly what it is. So it's more common than asthma, more common than seasonal allergies such as hay fever, and it represents quite a significant number. So in Canada, almost 60% or 2/3 of all Canadian children have experienced some form of tooth decay, between that 6 and 11 age group. Here in Ontario, through our screening programs, we've noted that 1 out of every 4 kindergarten kids in Ontario have had some form of tooth decay. We also know that it's the leading cause of day surgery, and so what that means is kids who go into the operating room and then are discharged and able to go home that evening for fixing their teeth. So more common than things like getting your ear tubes done or eye correction surgeries. Going into to fix your teeth represents the highest rate for outpatient surgery. And then we have data that showed us that children living with various disabilities are affected 3 times more. So, what are some of the outcomes that worry us? Of course, the obvious is pain or infection, that come up. That's a more acute problem, but this leads to longer term challenges. So, tooth loss is the most immediate, but usually because I work with children, I see the progression into their teenage and adult years, where infection, pain, tooth loss in young kids usually progresses throughout the teenage years and into adulthood. So it's kind of a progressive disease if the oral health environment isn't in an optimal condition, and this ultimately leads to challenges in nutrition or maintaining adequate weight. We've seen studies where it's affecting kids at school or adults at work, their ability to focus or concentrate at work, or just miss time from school and work in order to manage dental issues, which does have a broader societal impact in terms of just economic development, social functioning, your self-esteem. Lots of research showing that adults, and particularly with dental problems, have difficulty finding work or have self-esteem issues when it comes to even job interviews if they're missing front teeth. And then, of course, there's the burden of cost, both on the individual, because dental care is generally not covered, outside of private insurance, or cost to the healthcare system in general if you need to go to the operating room or into the emergency room to get your teeth looked at because you can't find a community provider. And it was really kind of the first time when our last national dental survey came out that we really started to quantify some of these numbers. So it was almost 40 million hours are lost from school or work activities due to dental problems, or school days and working days lost. And we haven't seen much change in oral health policy up until this point. So almost 50 years of kind of the status quo. But when we started quantifying the impacts on the broader society, we started seeing more movement when it comes to more equitable access for dental care. And we'll talk a little bit towards the end about the National Dental Care Plan that we see and how that kind of came to be. Further, if we look at Ontario, so this was back in 2014, almost 60,000 visits to the emergency rooms for dental related problems or toothaches. And these are typically individuals who, again, can't get to a family dentist for various reasons. And again, when you go to the emergency room with a toothache or a dental problem, it's very limited in what can be done. So it's usually temporary or palliative care, and this usually involves either antibiotics or pain medications, which contribute to to other public health issues that we're dealing with right now, and whether that's antimicrobial or antibiotic resistance, as well as opioids for pain management. So dental treatments not being necessarily given and contributing to other challenges in terms of our population. So why is oral health important? So obviously, pain, immediate acute pain and infection are concerning, but we know quite a lot now about the links to our mouth to the rest of our body and how those systems are connected. And so, it's pretty much well established and accepted, even by members of the government and national associations, that you can't be healthy without good oral health, and they're really one and the same for that. Um, so, this really comes down to, the other main kind of condition that we worry about in periodontal disease or gum disease. So from our national data, we know that, almost a third of all Canadians have, the early signs of gum disease, so gingivitis, as well as, almost a quarter have more severe periodontal disease. And so the main difference is gingivitis is reversible. So that's just an inflammation of your gums, sometimes mild bleeding of your gums. When you get to chronic periodontal disease, you have the inflammation in your gums, but you also start losing some bone and attachment to your tooth. And if it's untreated, you'll end up losing teeth down the road. And so, this is a issue that progresses with age. So again, when we think of periodontal disease, we think of more of an inflammatory process. So not necessarily bacteria causing a local insult to the tooth, but rather a systemic inflammation causing the problems. And this is just an illustration to show you that there is bacteria. This forms in the pockets of our gums. There are a whole bunch of cells that are activated to fight off that bacteria, but in the process they're producing a lot of inflammatory mediators. We'll say that one can cause some local breakdown of the bone and the gum tissue, but two, this is now in the bloodstream, so this can travel to other organs and systems within the body. And that's exactly kind of what research has shown us over the last 10 to 15 years, is that the same kind of inflammatory cells and bacteria that we see with very specific chronic diseases are the same that we see in our gum disease. And so there is that kind of link or that pathway between our oral health and some of our other systems. And this is just kind of where we are with the research. So the conditions here with an asterisk beside it are probably the ones where we have the best quality evidence. So either moderate to strong evidence that are linked to oral health. So whether it's cardiovascular disease, specifically strokes, diabetes management, respiratory diseases such as aspiration pneumonia, or adverse pregnancy outcomes. So there's enough evidence to know that if you don't maintain your oral health at these times, you can worsen your chronic medical issues. And again, this is also factoring in beyond just our individual oral health, is a basic understanding, and perhaps more critical beyond our health behaviors, is just all the other factors that really prevent us from reaching optimal health. And I think especially in the last 10 years, we've become a lot more sensitive and responsive to this in healthcare, but still have a long ways to go. But generally understanding how income and social status or education can create barriers that affect our ability to receive care and maintain optimal health outcomes. And it's very similar when we look at oral health versus any chronic disease, that these factors are trumping individual behavior, in a sense that if we don't take care of some of these issues, we're never going to have a healthy population that can reach these issues. So a little bit specific now to FASD in terms of what we kind of know and what we don't know. So a lot of this work for me, anecdotally, I would treat pretty much any patient who came into my office, and we would just note that um, you know a lot of children with chronic medical issues, whether it's neurodevelopment or um, other systems involved, it was always a challenge to treat them in the chair, for many different reasons, whether it was age, the extent of their tooth decay, many kind of adverse outcomes associated with different conditions that just made um, accessing care for them and delivering care difficult. There was some specific projects that we worked on at the time that was it was through the Public Health Agency of Canada, where a research group of mine, we were working at just looking at individuals who are living with various disabilities across many different kind of chronic diseases, and the challenges that they had accessing dental care or the specific barriers. And one of the notable omissions at that time was individuals with FASD. There really was no research or data one way or the other, even though anecdotally we knew that this was a population that faced many different challenges for accessing dental care in a timely fashion. And so, some of my work in this area came from just realizing that, we don't know how much we don't know at the time. And so, I'll talk a little bit first in general terms on individuals with special needs, because we perhaps know a little bit more or learned a little bit from looking at some other conditions. And so, if I were to generalize some of the challenges that both children and adults with various special needs run into when it comes to their dental care, it's understanding that each individual is going to be unique, and there's usually a variety of different risk factors that are brought into this. And so, some of it comes through medications. Various medications will again decrease either the quality or the quantity of saliva. Some medications can change the appetite. Some medications are sweetened, in order to make it more palatable for children. So these all have a very specific risk. A lot of these individuals might have difficulty maintaining oral hygiene. So whether it's the individual themselves or caregivers, due to just difficulties in daily living, we'll say. So it's very invasive to have a toothbrush if you're averse to certain stimuli or sensations. And so it becomes a challenge for caregivers to just be able to brush teeth, or even look in the mouth at times, and that can be detrimental at times. And so fully understand that additional supports are needed in order to help with that. With some children or adults, there are issues with muscle tone, so the ability to move the tongue, move the cheeks, that all has a natural cleansing function to help clear foods from the mouth. And sometimes it's challenges with swallowing or just moving or swishing things around in order to clear food out of the mouth, and that can be impaired. Dietary concerns. So again, if a child only has a limited diet and it tends to be carbohydrate heavy, you're feeding that bacteria at a rate that is good for your body and your growth and development, but may not be ideal for the oral environment. And then again, just the oral aversion. So sensitivities to various stimuli, particularly touch, can make it very difficult to examine and or maintain hygiene within the mouth. I show this slide just as an example. So, specific to FASD, traditionally, we were more worried about, the specific stages in development where the teeth and the palate or structures of the mouth may be affected. But we've kind of learned enough that, while there are certain times where there could be, malformations in the tooth itself, as an outcome, really it's more the challenges that develop later on in gestation with, functional outcomes or that result in difficulties in daily living that really affect the ability to maintain oral health care. So while there are, sentient kind of facial features associated with FASD, those aren't as linked or associated with oral health outcomes as we once would have thought. So it's really more of the difficulties in daily livings that are typical to some neurodevelopmental disorder, but understanding that every individual is going to be affected differently by some of these things. And so whether it's growth delays or deficiencies, challenges in daily living, motor coordination, or even just social adaptation. So coming into a dental office to be examined, can be a challenge, for a lot of these individuals. So we've learned quite a bit over time on different barriers to access to care. I'll go through a few of them because they are relevant. Physical barriers, whether some offices are wheelchair accessible or really um, going beyond that. So, for a lot of children, adults, it can be difficult just sitting in a dental chair, whether it's due to motor challenges or if they're wheelchair bound. Many offices aren't equipped for that. While it's a requirement for offices to be retrofitted with basic accessibility, whether it's ramps, it's not yet for specialized dental operatories where you might have a lift in your office to help someone who can't get into your chair, or larger rooms, we'll say, to make it more accessible for multiple family members or support workers. So still quite a lot of physical barriers to achieving dental care. Communication barriers are a big one in terms of just the ability to connect with an oral health care team or medical providers in general, but building that trusting relationships with the oral health community has been a challenge, as we've seen. Particularly comes down to a lack of training as it relates to individuals with disabilities. So, it's not well covered in dental school. It's often covered more in postgraduate training, whether it's through pediatric dentistry or basic hospital residencies. But a lot of incoming dental students who are entering the profession don't have as much experience dealing with the subtleties that a lot of these individuals have, and how to provide competent while compassionate care, and really getting to understand the challenges that are faced with their oral health. The obvious one is always financial barriers. So we live in a system where most of dentistry is private care. So if you're not insured or can't afford out-of-pocket pays, it becomes very costly to receive dental care. This is compounded with the fact that there are social support programs out there, whether it's through the provincial government for low-income individuals or through um, very specific programs for individuals with different disabilities. However, sometimes navigating or even just applying for these programs can be a challenge for a lot of our patients. And so sometimes even having coverage is not going to help you get the care that you need. Attitudinal barriers. So, we've definitely seen some stigma when it comes to oral health providers and their ability or willingness to treat individuals with disabilities, whether it's because they don't feel competent enough due to lack of training, or they perceive other barriers such as the time it might take, or the lack of resources within their own office. And so it becomes a challenge for finding providers for these populations. And then some systemic barriers are also there in terms of just a lack of specialists, particularly for individuals who are adults, with special needs, and just long wait times for appointments to see a specialist at times. So if you need to be treated under general anesthesia in the hospital, sometimes you could be waiting up to a year, and your teeth end up just getting worse throughout that period. So finding timely access is definitely a problem that we acknowledge. So, I just wanted to highlight some of at least what we've learned in the last kind of 5 years. So, a lot of this work that, my group has done was kind of with the support of the Saskatchewan FASD network. And so they were really receptive to, helping develop these questions and to learn about, at least what was happening in Saskatchewan at the time. So, the first thing, we just wanted some basic epidemiology as it relates to children in this case. So, what was their oral health status? How can we quantify it and use that then for further advocacy for resource? So, this was just a chart review of, some of our teaching clinics. Um, and what we found at the time, so I think this was back in just right before the pandemic kind of hit, but children who had a diagnosis of FASD had a higher likelihood of requiring provincial dental care support through the various programs in Saskatchewan, definitely had a higher level of tooth decay or dental caries, almost 5 times more than children without FASD. And then more kind of shocking to us at the time was they were almost 5 times more likely to require treatment under general anesthesia, and that was kind of after we had controlled for other variables such as age, the presence of or the diagnosis of FASD. So once you kind of eliminate some of those other variables, they were still more likely to be treated under GA, which indicated more of a professional kind of approach or possibly the stigma involved when these patients were being seen at the time. So it was enough information that we could at least quantify some of the challenge at the time, which led to further studies. The next thing we kind of looked at, this was a survey of caregivers, trying to really understand what some of the specific barriers that these individuals might be facing. And so, there had been similar studies that looked at children or adults with autism or other neurodevelopmental conditions. And so we wanted to see if it was comparable or if there were unique barriers that we weren't seeing. And so, through this survey, it was a provincial survey at the time, we found that, a lot of these children, with FASD, um, you know, they weren't able to get to a dentist in a timely fashion, so it was lower than our national averages. Similar barriers, and I'll go through a list of some of them that was seen with um, other kind of chronic diseases and, the social determinants of health. So income, education, um, amongst caregivers was definitely a higher risk factor for some of the challenges that we were seeing. So, highlighting just some of the barriers here on the left. So, a lot were kind of environmental or external. So the location of the office, particularly, the location of a specialist office who is willing to treat the children. Other transportational, so whether it's you're on a bus route, or the bus schedule was um, conducive to the specific appointment times you were given. Cost was definitely a big barrier, or just inconvenient appointment times and a lack of flexibility, from some of the dental offices in the area. There was some very specific personal related barriers. So, it's, caregivers who could be overwhelmed. They have a lot of other visits, other healthcare needs for their children that took precedent. Worried about the child's ability to communicate in a dental office, or of the dental office team ability to communicate with them. General anxiety towards dental treatment, and sometimes this is projected from caregivers onto children that we see, or just the burnout amongst caregivers was quite another factor. And then lastly, we kind of group them into our interpersonal skills. So an inability to find a specialist who's able and willing to treat, a lack of knowledge amongst providers about FAST and kind of the subtle um, adverse outcomes that might be associated with it and how to kind of overcome those when it comes to dental treatment. And again, there were some reports of, just not being listened to in terms of concerns they're bringing forward, or disrespectful or even discriminatory. So kind of that stigma that could be attached, that they were reporting to us. So again, this became powerful information for us to help reform, or at least look at some programs a bit more carefully. The last kind of aspect that we worked on was, starting to now quantify, how is this affecting quality of life, for these individuals. So this was a series of 3 surveys that we had sent out through the network. And so we looked at first adults, then we looked at adolescents. So the kind of the 8 to 15-year-old, and then we were looking at preschool children. So how were their dental problems affecting their overall quality of life? And we have a very specific tool that we kind of look at or use for this. So now to measure oral health related quality of life, we ask questions about physical pain, functional limitations, psychological discomfort, social debilities, and they're all kind of based around a specific set of 14 questions. So this is the oral health impact profile, but really looking at so under functional limitation. So the questions are phrased, due to problems in my mouth, have I had any trouble pronouncing any words? Or have I had any painful aching? All the way to things like, have I been self-conscious about my teeth, or I can't enjoy foods or social engagement, or been embarrassed. So it looks at a whole variety of different domains, and then we can kind of score and compare to other populations. So, what we found amongst adults and the adolescents was pretty consistent that, in pretty much across the board, these individuals were reporting, lower health related quality of life scores. So their dental issues were disproportionately affecting their ability to thrive. We also found that there were unique barriers, particularly as it relates to accessing care. So, beyond the common ones of proximity to a provider and cost, issues related to just the ability to find providers who were able and willing to accept these individuals, whether it's due to their just expertise or not. And it also helped reinforce the idea that we need to start doing a little bit more to recognize how some of these health outcomes affect our quality of life, because really it becomes very important in terms of advocacy. So the last part I kind of want to talk to is just some basic notes about oral health care in Canada, and some of the cracks that we have in our system. So, really, we know it's pretty common knowledge now. If you visit a dentist, it's costly. Most of our healthcare system is, publicly funded through the provinces in terms of hospital care or basic medical care, but our dental system has evolved in a completely different direction. So mostly financed and paid for in private dollars, whether that's out of pocket, private insurance, and mostly delivered in private clinics. So, I mean, we do have some hospital care, we do have some community-based clinics, but the majority tends to be in private offices. And so, that itself creates a challenge. If you're not insured, or you don't live close to a dental office right off the bat. So there are system level barriers. If we look at funding for dental care in general, compared to the hundreds of billions of dollars spent on regular healthcare or general healthcare, dental care, this was post-pandemic, represented about $18 billion. But again, the majority financed through private means. So, just a small proportion, 6%, came from government funding, whether at the provincial or federal level. We are going to see a spike in that, and I'll talk about that in our last few slides with the federal program, but it still represents a very small piece of the funding envelope. So again, just comparing to hospital and medical care, so, almost 70% of our general health care is publicly funded. Private care tends to be more pharmaceuticals, physiotherapy, and dental care. So usually the best way I look at it is historically we blamed individuals for their oral health. So you have control over your diet, brushing your teeth. So why is it a social responsibility? And that again predominated for since our Healthcare Act kind of developed in the 50s and 60s up until recently. But we're starting to realize a little bit more that no, we do have to take care of these individuals. And this figure here just shows a general trend in funding for dental care. So if we look at the blue line at the bottom, going back to the 70s, you can see there's really no change. So there haven't been, much investment in terms of dental care compared to private fees, which have consistently gone up, over the years exponentially almost. This last dip we see here was during the pandemic. So obviously, dental offices were shut down, and it was only emergency care. So there was a notable decrease in spending at the time, but we expect that to bounce back up in the near future. But again, just looking at some data as it relates to costs, so almost 17 to 20% of individuals just can't get the care that they need to cost. So um, if you don't have insurance, that really limits your ability to get timely care here in Canada. And this figure here shows a comparison between other critical healthcare services. So compares low-income adults to high-income adults. So you can see, in all cases, whether it's filling a prescription, having a medical issue but not being able to see a doctor or a medical test, if you come from a low-income household, you're at a higher risk for not seeking care. But dental care here on the left is clearly an anomaly when it comes to other healthcare services in terms of the proportion of what we're seeing. So there is some source for optimism. So again, with good data comes a better way to make a case to policymakers and lawmakers. And this really started going back to maybe 2015, 2016. So a lot of research from the last Canadian Health Measures Survey was done, and we were able to quantify some of um, the inequities when it came to dental care in Canada, to the point where it actually became an election issue. So going as far back as 2018, we started seeing dental care as um, you know, a focus for a lot of political parties. Even getting to the point where it was one of the major issues that was keeping a minority government, in play. So again, it speaks to the need on having good data and presenting in a way that can advocate for change. And then that kind of led us to where we are over the last couple of years with the new federal Canadian dental care plan. So this was a major investment in oral health, at least at the federal level. And there's it's not a perfect system. There are still many challenges with it, but it's probably the largest influx into the public side of dental care that we've seen in Canada. Going back to the 60s. So, an important thing to note is, if you remember back to one of the first slides when we looked at that 15%, so, our data, identified priority populations. And, when we looked at the rollout of the Canadian Dental Care Plan, there was a carve out specifically for these groups, to be included in this plan. So whether it's younger children, individuals with disabilities and seniors, and particularly so there was some attention paid to at least acknowledging that there are unique challenges for these group that needed to be addressed that weren't being addressed otherwise. So there was some promise there that they were at least listening, and looking at some of the data that was out there to date. So the program officially launched last year and began accepting patients. We've seen over 5 million Canadians who've approved, had their applications approved. Over 1 million who've received care to date, and over 25,000 or healthcare professionals providing care. So whether those are dentists, dental specialists, dental hygienists, are all involved. But we still kind of need to acknowledge, while this is promising, a lot more Canadians are getting the care that they need. There's still a lot of barriers kind of involved. So again, if you are eligible for this program and have the funding to pay for dental care, you still need to find a provider who accepts it, and one that's relatively close to you. So this still doesn't address some of the disparities that northern communities faced, or individuals with various disabilities, in terms of finding a provider who can actually treat them. So again, it's keeping in mind that there are other barriers beyond just cost. Most public plans will help address the cost, but we still have a lot of work to do when it comes to distributing our providers into other communities, making sure we have enough specialists who are competent and willing to treat, while working on providing compassionate and comprehensive care. So again, most of these plans, they do address the financial barriers, but just realizing there are still many other barriers that are preventing our patients from coming to receive care. In terms of kind of next steps, I think this is my last slide here, as I see it pop up. Really, there's a lot we can do and need to be doing. The first really deals with prevention. So, if we look at to one of my first slides, that 2-year-old with the early signs, these are some things we can absolutely treat without general anesthesia. And so we need to develop a better system where, kids are screened at an early age, and we're looking towards less invasive procedures, in order to prevent disease from getting worse. We have a lot of reform to do within our education curriculum in terms of treating providers who, can handle a wider variety of patients, and then really on the advocacy kind of side in terms of working with government. We've done a lot more work here in terms of this interdisciplinary approach. So I work with a lot of therapists to help them come up with strategies to maintain oral hygiene, or even with some of the school boards who have programs in order to help reinforce based on individual plans they have for children in order to kind of incorporate different strategies into their oral health care. But it takes a bit of work to develop those kind of networks. So with that, I'll end. I see we have some questions already popping up, but again, wanted to thank the group for inviting me here today. It's probably not often you get to hear about oral health, so hopefully you learn something, and hopefully not too discouraged, because we have we acknowledge and address the problems that there are, but there's been a lot of good work to get more people on board with the idea that again, our oral health is important to our overall health, and it's enough of an issue that it almost shut down the federal government for a while, um, in terms of one of the bargaining kind of chips. We'll take anything we get for that, but a realization that we need to be doing more for some of these vulnerable populations.
Thank you so much. Sorry. Thank you so much, Dr. De Silva. That was a wonderful presentation. And like you said, we already have a lot of questions pouring in, so let's just jump right into it. So the first person here has stated that I live in an Inuit community in Nunavik, northern Quebec. Our dentistry services are poorly lacking. When dentists come here, they do a lot of extractions of abscessed teeth. There's very little prevention in terms of cleanings, etc., starting with young children. Many young adults are already getting fitted for partial dentures. Some cannot even chew traditional food or digest it well. Many people are medicated for dental issues, which cost thousands of dollars. Some people even pull their own teeth. Since we know that gum disease and heart disease are linked, how can we see policy changes at the government level, both provincial and federal, that frame good dental hygiene as an investment in future overall wellness?
Yeah, so I've definitely agree with you, and I've heard many similar stories. Even in my time in Saskatchewan, I would spend a lot of time going up to some of the northern communities. Sometimes it was training, of physicians and nurses or dental teams if they were there. But the distribution of dental providers in northern areas is sorely lacking, and that's been an ongoing problem. In terms of how can we see policy change? So one thing I learned, and this was really in my transition from clinical care to the public health side of things, is one, policy change is horribly, horribly slow in terms of making inroads. And sometimes you don't know when your window will come, but you have to keep, presenting the data until you find, willing advocates on the government side to help um, move your cause forward. So we've known about the links for oral health and systemic health for a long time now, but really only in the last 15 years have people actually been repeating and acknowledging that importance. So it was a small victory and nowhere near enough to make movements on improving individuals' health, but it was an important change. Recognition of that itself was part of what led to a federal program. Now, again, this is not a perfect program, and it still does not help northern communities. There's other funding envelopes through the federal dental plan in terms of grants that have been slowly rolling out to help with different strategies for northern communities, but it's nowhere near enough, and still a slow process. So I totally understand the feelings there, other than to say that it's been acknowledged and people are working on it. I just as an advocate myself, I wish it could be done faster. So again, we have seen some philosophical changes in realizing that it's not just an individual's responsibility. We have to do more in terms of our social responsibility for providing equitable care. Now it's a matter of, just because we have a federal dental plan, realizing that there are still populations who, despite having funding, still can't get to an access, and chipping away at those barriers.
Thank you. The next question here is, our child needs orthodontics after after tooth extraction. They are autistic, level 1 with ADHD and FASD. How can we support through this major change? And is a general orthodontic practice appropriate for the understanding of these challenges we expect will be high for our child? Are specialist providers available? The oral surgery the oral surgery plan seems sound.
Yeah, so there definitely are a lot of orthodontists who are comfortable and capable of treating individuals with whether it's ADHD or FASD. I can't say that all providers are created equally and are willing, but many of my patients with some of these issues we've seen go through orthodontic treatment. So sometimes it's modifying the overall treatment expectations. So you might not have someone who's willing to sit through orthodontics for 5 years, for example, but there perhaps are limited options for a shorter time frame to make sure that you have things looking healthy and that it can be done. So in terms of finding an actual provider, the first is usually contacting one your regular or routine general dentist to see if they have any recommendations, because they usually would be tapped into individuals who are more willing to go down this road. If not, the provincial dental associations that are a good resource, because they often have internal lists on where we can send some of these patients. That again, then brings up the challenge of, well, what if the nearest provider is not um, you know, in my area, or I have to travel 3 hours for what would become monthly orthodontic visits. But I can say I do know of individuals, that would be more than willing to do it.
Our next question here is, dental care for our granddaughter in our care is not impacted by socioeconomic issues. I have dental coverage and an excellent dentist, and despite anxiety in other situations, she has managed dental visits quite well, laughing gas sometimes used. Our big issue is her non-compliance to caring for her teeth. When younger, I could do it for her and with her, but as a teen and now 19, completely refuses to brush, floss for days at a time. Has 7 to 10 cavities every time she visits the dentist. What can we do?
Yeah, it's always a challenge. So there are two issues that kind of come up that I see, and um, when teenagers in general don't like listening to instructions, um, let alone when you have other kind of anxiety issues. And so it's very difficult to change that behavior. Two, what happens to a lot of teenagers is they may have a dental home with a pediatric dentist or someone who's really good with children, but when they get into the teenagers and adulthood, they lose some of that specialized care. So it is a challenge to reinforce proper oral hygienes, especially when they get to an age where you can't brush for them. And so sometimes it's working on small goals, getting to brush once per day. Sometimes it might not be before bedtime, but maybe during the day or after meals. Sometimes just starting with a mouth rinse that um, may help, or some extra types of toothpaste, or even there's some gum chewing habits in a sugar-free gum that might help clean the teeth. So it's be working with perhaps your family dentist to see what other prevention options there might be to overcome, or at least acknowledge that um, managing the hygiene at home is going to be an ongoing challenge.
Next question here. I'm curious if you have done or are interested in doing research on the oral microbiome in individuals with FASD.
Definitely, so I haven't done it yet, nor do I know of anyone who has. It's an interesting topic that definitely interested in exploring. And we do have the capabilities here, and there are two kind of components to it. So one is the oral microbiome as well as the gut, um, kind of microflora. There's some clear links for individuals with FASD, and I imagine there could be some very similar profiles for it. Um, there. So, definitely would be something to look forward to starting as a project in the future. So, very happy to chat offline about that if you happen to be a researcher or someone who knows about that area. I know more about the oral microbiome side, but making that connection to what we already know about the FASD kind of community, and just knowing how much information we can get, even from something as non-invasive as a saliva sample.
Very interesting. Here we have, why are providers or clinics allowed to deny care to CDCP?
Yeah, so it's part of the private nature of the um, dental care system where you can't force a private practitioner or um, clinic, will say, to accept any patient, one or the other. And that's kind of well acknowledged by both the regulators and um, the provinces for it. Do I agree with that? No, not necessarily, but that's just our system. So everyone's encouraged to participate in these programs. There are some historical challenges, so not necessarily with the CDCP, but a lot of provincial programs were grossly underfunded. So a dental office may only be reimbursed a quarter for every dollar that they're spending, which just wasn't sustainable. So there was a lot of kind of distrust with government programs, historically on it. But the CDCP, at least in its funding mechanism, has addressed some of that. So we are seeing again a lot more providers accepting it at this time, but there's still some practitioners who just have that distrust of the system. So the first part of that is, again, there's no mechanism to force anyone to accept a specific program or the other. Um, but again, it's just knowing that there were some challenges on the provider side with the programs. Again, we're hoping to see a change in that kind of philosophy going forward, but it's still a slow moving kind of an issue.
Sounds good. My 13-year-old with FASD is diagnosed with thin enamel from FASD and consequently frequent cavities, 9 in 1 visit. What is an advisable treatment for him long term for tooth health in addition to regular cleanings since his enamel is easily worn through? We get him medicated toothpaste and extra fluoride and fluoride varnish.
Yeah, so all those things at the end there. So the higher concentration toothpaste, there are mouth rinses you can get. The fluoride varnish helps kind of strengthen them a little bit. For the existing cavities they might have, the dentist may want to think about full coverage. So something that covers the whole tooth. Even if there's a small cavity, something like a tooth colored or a stainless steel kind of a crown tends to prevent secondary damage to the tooth down the road. So, addressing the current fillings your child need while preventing additional ones. That, and sometimes just more frequent monitoring. So sometimes you may need to come in more frequently, so every 3 months for that fluoride varnish, or just catching problems before they become cavities. So just increasing the amount of time that can be seen. And there are a lot of dental practices that will build that in, so you're not necessarily charged um, in the course of treatment, but something to explore.
Uh, Another one we have here is my daughter was 9 when she had her braces. She had precocious puberty and had Lupron for years. She had all her adult teeth by the age of 9. Have you heard of that before?
Oh, yes, yeah, absolutely. So I mean, we talk about kind of the common ages for development, but really, the number of teeth you have in your mouth is linked to your overall growth. So, if you hit puberty earlier, you're probably hitting your growth spurts earlier, and you're going to have more teeth earlier. So, if we look at a range for when um, you might get your adult teeth. For females, we might say anywhere between 9 and 13 years old. So it's quite a range where you might see all of your adult teeth. Boys tend to be a little bit later, so the 10 to 14-year-old range. That being said, I've seen some 7, 8-year-olds with all their adult teeth, minus their wisdom teeth and then the very back. And I've seen some 15-year-olds who still have baby teeth in there. So seeing a range is not something to be worried about.
Thank you. I think we have time for one more question before we close off. An additional barrier to oral care our loved ones frequently experience is executive functioning challenges that interfere with their ability to make appointments, remember appointments, and get to them on time. Can you suggest strategies that either dental offices or people with FASD could use to address this barrier?
Yeah, so from the dental office side, and it's a challenge I've definitely seen and heard from is, learning to be more accommodating. So if we have a family coming in with multiple kids, and they're taking one or two buses, to get to our office, we can't penalize them if they're 10 minutes late. Um, and that's an extreme example where it's not happening. So one, I think, more work has to be done on the dental office side in terms of, being more accommodating, understanding to an individual circumstances, and really booking accordingly for it. So, with my patients, I always like to find out what are the best times of day. Um, what challenge do you face on your journey here? How can we book our scheduling accordingly? With the built-in kind of leeway that unexpected things are going to happen in the day to day. From our patient side of view, you know, sometimes just communication. So, if a child is having a bad day, and just can't get out the door, letting us know that, and hopefully there'd be some compassion for that. And most, providers, particularly those, in pediatric dentistry who see this more often, are understanding of that. I think, but just the communication, I think, really, really helps from that side in terms of letting us know, and then letting us know what we can do to help. But establishing that trust over time, I think, really helps.
Thank you very much. Thank you so much, Dr. De Silva, for this wonderful presentation today and for all of our participants who are listening from across the province. I'd like to just close off the meeting now then, since we're at the end of our time. So take care, everyone, and stay tuned for more webinars by Health Nexus.